Thanks very much, Bob, and very grateful to be here. Actually, getting from LaGuardia to here in an hour is sometimes a little challenging, so I'm actually delighted. Thank you, Bob, for being so patient, and to Chris and the team for getting the slides on board. I loaded onto the website earlier this week a very comprehensive syllabus, and what I'm going to show now is a sort of distillation in each of the presentations I give this morning for you to sort of drill down to the key points. And my major thrust for this morning is really to emphasize that a proteasome inhibitor and IMiD backbone in the upfront setting is, I think, now established as a standard of care. And whilst obviously KRD is a phenomenal combination, we're very impressed with its activity, and the relapse data are very convincing. I'm going to argue that there's an old saying, and I honestly believe this is a true old New England saying, that you've got to keep your powder dry. And to some extent, you want to use sequences of agents in order to maximize therapeutic benefit over the long term. And by that, I mean that we need to use our most efficacious regimens, but also be rational about what we keep in reserve. We also need to be evidence-based and driven by what we see, because whilst relatively interesting new regimens are obviously very powerful and very effective, there may be some patients who benefit from it in particular and others who actually may not. And until we know more about that, my argument would be that we have now a track record with this particular platform that's well established. And at the same time, whilst I'm very excited about the promise of Carfilzomib in this setting, I would argue perhaps a little patience as we go forward and before we routinely bring it straight into the upfront setting. And to sort of emphasize a bit of background here, I would just emphasize that multiple myeloma, obviously we're understanding, is not just only a heterogeneous disease between patients, but very importantly, it changes within a patient. And I'm emphasize that point because, again, that gets to the key sort of takeaway that you need to use certain agents and certain combinations at certain times in the natural history of a patient's illness. Now, obviously, we all know that the area of smoldering disease is very exciting. There's promise of the immuno-oncologics in particular in this space. In the setting of active myeloma, I hope to convince you that indeed a proteasome inhibitor, an IMiD, and a steroid is the new standard of care in that setting. And it's very important to achieve a platform from which continuous therapy can be highly successful, be that with transplant or not, and we'll talk a little bit more about that later. What I emphasize, though, is in the old days, we used to think, well, once the horse is out of the barn, once relapse has occurred, the outcomes are dismal. That's perhaps true of old. It's not now. And I think when you see remarkable data like Aspire, for example, and other trials like it that show you can really enjoy long, durable remissions even after first, second, and third relapse now, I think it becomes very important to go back to that original point, that we do need to have in our armamentarium a sequential approach to certain classes of drugs that we can use rationally and adapt to each patient. This is very different to other tumor types, very different to the solid tumor world, where if once a class of agent has failed a patient, you're doomed if you go back to it. That's absolutely not true in the setting of myeloma. You can revisit classes of drugs and by so doing, reestablish response and do so to a degree that's unprecedented, certainly in our experience with this illness. A couple of points to make, though. Whilst obviously we're very optimistic about myeloma in the longer term, and I think we're very excitingly on the cusp of yet further progress, it's relevant to mention that there are early deaths in high risk, and I'm sure Ed and I, because we actually usually agree on everything, will very strongly agree that there may be specific settings in which you do want to reach for your most potent proteasome inhibitor that's available, and there may be others that you don't. Having said that, we also recognize there's no plateau. So again, going back to this concept, keep something in reserve because you may need it until the evidence supports it. And just to back up my point, I'm just going to refer to the NCCN Guidelines from this year. As you can see, there is a preferred category for RVD up front, and Carfilzomib, Lenalidomide, Dex is held as an other regimen, which is a rational choice, but not necessarily your first. On the same token, however, KRD is recommended in relapse, and I think that's a very rational approach. And obviously in that context, it gets a Category 1 designation because of the success of the Aspire trial. So let's back off a little bit and just think back to basic principles. In terms of where we are with induction regimens in myeloma, I think it's very clear that the 3-drug regimens have really revolutionized the platform. And in that context, the integration of a proteasome inhibitor and an immunomodulator together with the synergy that's been demonstrated first in vitro and now in vivo is well established. We know that Bortezomib-based therapy in the upfront setting is a key platform for improving outcome from phase 3 trials. This is an update from ASH in December from Pieter Sonneveld, where we see with prolonged follow-up, sustained PFS benefit to Bortezomib-based treatment and an overall survival advantage in this randomized phase 3 trial. And Pieter's conclusions are summarized here, where clearly a proteasome inhibitor as part of that platform becomes key. Now, I think as we think about where proteasome inhibitors line up with transplant, we'll obviously be talking about that more, this concept of toxicity starts to really matter. Because if you think about transplantation, you're stressing a patient with alkylator therapy. There's a lot of vascular stress associated with that approach. And so therefore, in terms of your induction strategy, you have to be thoughtful about the drugs that you use. And I just make that point because we'll come back to that in a moment. Now, 3 drugs versus true drugs. What's the evidence? Well, I just want to bring your attention to a very nice presentation from the IFM at the ASH meeting in December. This was from Philippe, where he compared VTD to another standard, Bortezomib, cyclophosphamide index as an induction strategy. And remember, the construct here is because obviously in the European setting, the combination of lenalidomide and bortezomib is not so easy to access. Certainly an established upfront platform is VTD in this setting and has been, again, validated in numerous settings. Having said that, what was demonstrated in this trial quite nicely was the superiority of the IMiD and proteasome inhibitor over the alkylator and the proteasome inhibitor in terms of response. In terms of tolerability profile, as one might expect, VTD won in the context of the myelosuppression. Neuropathy, however, is a challenge. And be the first to acknowledge that neuropathy really matters. And obviously, thalidomide is more neurotoxic than lenalidomide in this setting. And of course, bortezomib, given intravenously, is established to, of course, cause a significant signal. But we're getting much better at managing it, particularly with the advent of subcutaneous administration. Now, in the context of stem cell harvest, obviously, again, a win for the 3-drug platform. So the conclusions from Philippe's presentation were that indeed the platform of bortezomib and thalidomide versus bortezomib and cyclophosphamide was the winner. Hematologic toxicity was increased. Obviously, peripheral neuropathy is a challenge. With that in mind, in that context, the integration of lenalidomide-based therapy has been very important because that has significantly reduced the neurotoxicity associated compared to VTD. And the next step, which has been the advent of subcutaneous administration of bortezomib, has taken that yet further. This data is with intravenous bortezomib, so the tolerability profiles obviously have to be recognized in that context. But I want to, again, re-emphasize the point that with a subcutaneous approach and a more refined strategies for neuropathy, it's becoming less of a challenge, although remains important. The message here, though, obviously, is the remarkable response rates and the very high quality of response. And interestingly, when you add chemotherapy to this platform, you actually see increased toxicity. However, if you move next into the addition of next novel therapies, which we'll come to in a minute, the improvements are more striking. So very quickly, what evidence do we have at the phase 3 level for the superiority of RVD over other strategies? Well, a very important study presented at ASH was from Brian Dury and the SWOG team, and they showed very convincingly for all their endpoints, in fact, across their study, that RVD was superior to RD, both in terms of PFS and, very importantly, in terms of OS. And this led the Mayo Group to adjust their MSMART guidelines to now bring away VCD as their preferred upfront choice, and actually now they recommend RVD in that setting. Now, obviously, we've got new drugs on the horizon, and I want to especially acknowledge the fact that the advent of second-generation proteasomes inhibitors has been a game changer, and Carfilzomib clearly is the leader in that field. Ixazomib is hot on its tail. On the same basis, obviously, we have the further additions of HDAC inhibition to this platform, and I want to share some of that data with you. I also want to bring home the fact that monoclonal antibodies, which we heard so nicely from Ruben just a second ago, are now in the upfront space. So there's really exciting choices. And my argument would simply be, when you've got this sort of plethora of options, obviously one has to be very excited about that, but also cautious, because there may be both acute and long-term toxicities that we must be aware of before we necessarily adopt every new thing that arrives. Now, with that in mind, very much the pioneering work of Andres Jakubowiak in this setting has been very important. Andres has showed very convincingly the striking activity of this platform and the fact that KRD against adverse cytogenetics in the same way as RVD is very active. So great news. And the important message is here, no significant neurotoxicity. It's around 20%, which is great. However, I think we all recognize there's a small but real risk of this cardiopulmonary toxicity that is ill understood at this point. A very interesting paper just came out from the Mayo Group in the Blood Journal looking at this in a large cohort of patients in the relapse setting. And the conclusion from their clinical observation is that there is an endothelial and vascular toxicity to this platform that is ill understood. The clue actually comes in the ASPIRE trial, where the rates of deep vein thrombosis for KRD versus RD were threefold higher, 15% approximately for KRD, 5% or so for RD, with standard thromboprophylaxis. So I think we've got an interesting and important signal here that we need to better understand before we embrace absolutely in everyone an approach where, for example, Carfilzomib might be combined with Lenalidomide. Having said that, in my view, clearly if you have a patient at high risk of neurotoxicity, a very appropriate approach would be to use Carfilzomib in that setting. And I would absolutely agree with that as a standard. My point is, though, just be careful because this is real. It's small, but it's real. And we need to better understand in who and why. So with that in mind, as we add drugs to this platform, we also have to be careful. Because if we have HDACs, I think they're great drugs, a fascinating new class. What happens in terms of endothelial toxicity? We don't really know. Before we do that, however, there is nice data with the RVD platform for both voronostat and indeed for panobinostat, and this work has been led by Jatin Shah and Bob at the MD Anderson, really showing that with the subcutaneous administration of Bortezomib and a lower dose of panobinostat at 10, what Jatin showed at ASH were a remarkable response rate very early with MRD negativity in over half of patients after 4 cycles. So when you've got platforms of 4 drugs that can drive this, I think that's very, very exciting. And the key point is that your backbone provides you with a relatively safe and well understood and tolerable platform that can go forward. Similarly, in the context of transplant, we have the IFM experience with our partnership with them, with the DFCI and the CTN, and our whole big group in the US, the Determination study, was showing, in our own experience, remarkably high response rates and excellent outcomes for both arms. And the French presented their overall survival data at interim analysis. And as you can see, this is unprecedented. Very high rates for both arms, whether you have the transplant or you don't. And my point is that RVD as the platform here has been safe and well established. Now, what about if you dial down on RVD? And I want to acknowledge the work of my colleague Jacob Laubach with Betsy O'Donnell at the Mass General, where they've looked at RVD lite. This is a really exciting regimen, in my view, for the older patient. It's tailored to sub-Q and weekly. And the results that Betsy and Jacob have shown are really striking in the older population. Again, preliminary at this point, full manuscript to follow, but I just want to make that point. Finally, of course, there's Dexamethasone coming on the pipeline, which will be exciting in the upfront setting. Again, very well tolerated in the older setting, on the older patient setting. So my conclusions would be summarized here. As we think about this excitement around the new drugs that we have, let's have a little bit of a word of caution, because we've got to think in the long term. And until we better understand all the toxicities that we may be encountering, there may certainly be opportunities where Carfilzomib up front is very appropriate. And I would acknowledge first and foremost the ECOG trial that's ongoing right now, KRD versus RVD. Those results will be available to us in the next year or two, and they, I think, will guide us profoundly in the directions that we should go. And as I mentioned, tolerability here is absolutely key, particularly in the older adult. And I also want to make the point that we've got lots of new drugs coming, so this concept of sequencing and combination becomes particularly important in terms of efficacy, which is a function of activity and toxicity. So putting those two things together have become very, very key. And obviously the future is very, very exciting. So I think on that note, I just simply want to conclude with this important slide, which is a tailored approach to therapy is key. And in my view, there will be definitely patients who should benefit from Carfilzomib RD up front, but there may also be a majority of patients who may be, at this point at least, a safer choice to go to RVD in the bigger picture, with minimizing toxicity in the acute and long term, and obviously the outlook, I think, for our patients is excellent. This slide, I think, summarizes that, continued progress and real hope. And the other thing I just want to acknowledge is the remarkable partnership that's led to this. Our pharma partners, all the research teams in myeloma, both in the US and elsewhere. And in fact, with the recent melphalan, new melphalan, the less toxic form of melphalan, it seems, approved by the FDA, we now have 17 new approvals in the last 12 years. So on that note, thank you very much for your attention.